Hello, my name is Dr. Jean Storm. I am a physician at Lecom Health, and today I'm going to be talking about aspiration and dysphagia in primarily in patients in the long-term care population. So I thought we'd start with a case review. This is typical of a patient who comes into a facility for rehab. This is a 74-year-old man with a history of Alzheimer's dementia and chronic dysphagia. He also has a history of aspiration pneumonia. He presents with a urinary tract infection, hypovolemia, and hypernatremia. He's been on thickened liquids at home for several months. And as his overall condition improves with IV fluids and antibiotics, he requests to drink thin liquids, which is fairly common. So let's start with identifying the problem. Dysphagia is defined as difficulty in eating or swallowing. It can manifest in several ways. As painful swallowing, you also may have a patient who presents with the feeling of food getting stuck in their throat or in their chest area. It also can manifest with a patient not being able to swallow at all. The prevalence of dysphagia is fairly high in the nursing home population. The Nutrition Day Project did a study of almost 24,000 nursing home residents, and they found an incidence of 13.4% of patients with dysphagia. Though it's interesting that residents who were malnourished or dehydrated often had more symptoms of dysphagia. So, one needs to question what comes first, the dysphagia or dehydration and malnourishment. So aspiration is the most feared complication of dysphagia, and this occurs when material from the oropharynx or gastrointestinal tract enters the larynx or lungs. And this is obviously a fairly significant complication of dysphagia. So this picture is fairly simplistic, but as you can see on the left, we have the normal route of that food and drink goes when you take a swallow, that the food and drink then goes down to the stomach. If you have a patient with dysphagia, food and drink can go down both the lungs and the stomach. So let's talk a little bit about aspiration pneumonia. It is the general feeling is that it constitutes 5 to 15% of all cases of community-acquired pneumonia, and it has a relatively high mortality rate of 21%. So it's something that we all have to look out for and do our best to prevent. Aspiration pneumonia obviously is clinically significant as it has a very high mortality rate, though there is no universally agreed upon criteria to diagnose. Typically it's something that we suspect based on radiologic findings and exam. It's very important to identify individuals who are at risk for dysphagia so we can prevent aspiration pneumonia because it carries such a high mortality rate. So how do we make the diagnosis of dysphagia? The bedside swallow assessment is one of the simplest and least invasive ways to determine if a patient has dysphagia. I think sometimes in medicine that we feel that the simplest things aren't valid, and in this case it is. It's a very valid way to make the diagnosis. So how do we do a bedside swallow assessment? Essentially, we have the patient sit upright at 90 degrees, and then we administer small sips of water. So each sip is typically less than 20 mLs, and then we administer consecutive sips up to 100 mLs. Then with each sip, we watch the patient for signs of choking or coughing. which might indicate that the person has dysphagia or is aspirating. This simple method is carries a very high sensitivity of 91%, which is fairly significant. So this is something that we should be employing initially in individuals who are able to follow commands, and if we suspect that there is a diagnosis of dysphagia. There are other ways to make the diagnosis of dysphagia. Modified barium swallow or a video fluoroscopic swallow exam can also be used to make a diagnosis of dysphagia. So they allow direct visualization of all aspects of swallowing. Essentially, we have a patient go into the radiology suite. Usually a speech therapist will meet the patient in the radiology suite and discuss what's going to be happening. And then barium in various textures are given to the patient, and then swallowing is observed basically in real time. So video fluoroscopic swallow exam is considered the gold standard in making the diagnosis of dysphagia. It really should be noted that this is time consuming, and a patient has to go out of the facility. And in these times of COVID, obviously, that has been a challenge to take people out to get these tests done. The test can also be expensive. So that's something that we need to keep in mind. What is most important to keep in mind with these tests is that it is not proven if the findings that we see for VFCE can be translated to functional ability to eat and drink. So that basically means that we're not completely sure at this point if the findings are valid to be utilized in clinical practice. So swallowing barium is obviously not the same thing as swallowing real food and drink. So that's something that we have to keep in mind, I think, with all tests, that we have to look at the entire picture instead of just making a conclusion based on what a test tells us. So this is a picture of a swallowing exam, and you can see the dark areas are the barium that the patient has swallowed. So you can kind of see this in real time and see what all the anatomical, how things are moving together anatomically, and kind of see if something is going down in the wrong area, if there's pooling of the barium in any part of the oropharynx. So why do we use thickened liquids? So basically, we have our patient who is assessed with a bedside swallow or with a barium swallow or a VFCE, and perhaps we decide to place the patient on thickened liquids. So why did we decide to use these? The use of thickened liquids began after a study that was published, and it was a fairly small study of 46 patients, and these patients had a stroke or traumatic brain injury. And so the use of thickened liquids in these patients led to a decrease in aspiration when it was visualized with video fluoroscopy. So we didn't give these patients thickened liquids in real life and observe them for aspiration. They observed them with testing. So it's important to note that these findings led to a presumptive decrease in respiratory complications. So several studies have also followed, but they used imaging findings to guide clinical practice. So that's something to think about. I do believe these tests are useful in some regard, but we have to utilize the test results as part of the entire clinical picture instead of relying on them solely to guide us in our treatment options. So what are the risks of using thickened liquids, and are there any? So individuals who are given only thickened liquids have been shown to be at higher risk for dehydration, urinary tract infections, and fever. We've seen this in studies. Individuals typically express lower quality of life when they are given only thickened liquids. They report decreased quality of their life. And this is something I believe is very significant. These are individuals who are in long-term care facilities, so they typically are at the end of their life. And so if we decrease the quality of the small amount of years that they might have left, I think that is something that we have to think about. Compliance to thickened liquids has been reported to be 35% at 5 days. So it's fairly low, the amount of individuals who are compliant with our thickened liquids. When are they helpful? If a patient has extreme coughing with water intake, and it might be, and this coughing is causing exhaustion and extreme stress, it might be reasonable to utilize thickened liquids to minimize the coughing. Thickened liquids can also be used at the end of life in individuals who do also have extreme coughing, just to make them more comfortable, as from a quality of life standpoint. The studies have also shown that thickened liquids and modified texture diets, if they're combined with intensive speech therapy, they've been found to be helpful in reducing aspiration pneumonia in the 7 days following a stroke. But it's important to keep in mind that this risk reduction did not extend beyond the first 7 days. Water. So allowing patients to drink free water is important for hydration and overall quality of life. We're human beings, and I believe we were made to drink water. So it's important that we involve the entire team in a long-term care facility to employ strategies to prevent aspiration, and to ensure that a patient can drink water if they are able. So we utilize positioning, oral hygiene, and education. It's important to discuss and educate about a chin tuck posture, have the patient swallow in a chin tuck position, as this is demonstrated to be superior in safety to thickened liquids without any difference in rates of aspiration pneumonia. It's also important overall for good oral hygiene, as if we can reduce the number of pathogens in the mouth, that's going to reduce the number of pathogens that the patient is going to aspirate if they do. And obviously pathogens cause pneumonia. Tube feeding. So if dysphagia is a result of a surgical alteration of the larynx, if they have a cancer, or if they have a deficit from stroke, which is affecting their ability to swallow, tube feeding is preferable over oral feeding. It is important to note that tube feeding has not been shown to reduce the risk of aspiration pneumonia compared to oral diet. So if a family asks you to put a tube feed in someone to prevent aspiration, you can let them know that there is no significant difference over oral diets. So let's talk a little bit about free water protocols. So patients are screened utilizing a bedside swallowing assessment, which we already discussed. If the patient is unable to swallow directions, if they have excessive coughing, or if they're unable to limit themselves to small sips, then it is recommended that they are limited to supervised sips of water between meals. But we have to make sure that we perform oral care, good oral care, before we give them sips of water. Patients are encouraged to sit up and to employ a chin tuck when they swallow. And when we follow these simple steps and give patients free water using the free water protocol, patients have said that they have improved quality of life compared to those who are receiving thickened liquids. It also is always important to get families involved in the decision regarding utilization of free water protocol or thickened liquids. You have to discuss the risks and benefits of both and really have the family help you make the decision. And then always document a summary of the discussion with the family. So back to our case review. This 74-year-old man with Alzheimer's dementia and chronic dysphagia with a history of aspiration pneumonia presents with urinary tract infection, hypovolemia, and hypernatremia. He's been on thickened liquids at home for several months. And as he improves with IV fluids and antibiotics, he asks you to drink. So what is the best course of action in this case? And it's a good outcome, though I've seen some cases that were not so good with thickened liquids, but this one was good. So the results of our case review. So this patient was assessed utilizing a bedside swallowing assessment, and he has mild coughing when he drinks water. So the family is involved, and the discussion is had with the family, and the patient continues to ask for thin liquids. So the practitioners proceed after they discuss the risk of aspiration with the family. He's given small sips of water in a supervised setting, so he's watched closely after he's sat upright and after he has good oral hygiene, and the chin tuck swallowing is discussed with him. He continues to improve during his stay, and he has no complications from drinking water. So in this case, it was done in a way where the patient, was able to enjoy drinking water, and that, kind of improved his overall quality of life, which then can help, improve health overall. So this is a good case. So a few take-home points. Dysphagia is common, especially in the long-term care population. And aspiration is a serious complication of dysphagia. The easiest way to screen a patient for dysphagia is by utilizing a bedside swallowing assessment. Modified barium swallow or a video fluoroscopy exam can also be used to make a diagnosis, but you have to keep in mind, we have to keep the findings, keep in mind with the whole entire patient picture and not rely on them alone. Thickened liquids may be useful in certain situations, but we discussed the risks that they also carry. Tube feeding does not reduce the risk of aspiration pneumonia. Free water protocols have been shown to increase the quality of life in patients when we follow a few simple steps to utilize them. And it is always important to involve family in treatment decisions regarding thickened liquids and free water protocols. Thank you very much.